Are you able to see that?
I am, yes. Thank you.
Wonderful. Well, hey guys, thanks for joining us. We're trying a little something different here. Again, we used to do kind of lunch and evening community reach out things where we'd educate the public and patients about different common topics. And we decided to try this online given the COVID situation. And we also decided this time we'd try a little different time. We've been doing these at lunchtime, but we thought that a lot of people were busy at work and whatnot. So we tried in the evening. So we'll see how this goes. Again, this is all designed to be educational and helpful for our patients and our team members, but it also is a little bit of a work in progress. So bear with us. The topic today is tennis elbow. And I put here that it's not just for tennis players because as it turns out, a lot of people I see are not tennis players and they still have this common problem. So we wanted to talk about this. The idea was that we would educate a little bit about the etiology of this, talk a little bit about the diagnosis and the non-operative treatment, and then also talk a little bit about the treatment options for patients, primarily being non-operative actually. People think that we're surgeons and so everything we do is operate. And it turns out that a lot of these things can be treated non-operatively, and I think that's important to educate patients on. So for those of you who don't know me, my name is Dr. Kennon. I am an orthopedic surgeon here at Tennessee Orthopaedic Clinics in Knoxville. A little bit about who I am, and I apologize to folks if you've seen these couple slides before. I'm from a small town in eastern Georgia called Oxford or Covington, Georgia. This is a picture of our quaint little hometown square there. So I grew up in a small little town. I also spent a fair amount of time living here in East Tennessee. So I spent my fair share of days in Neyland Stadium and enjoying the sights and sounds of East Tennessee and UT football. So I am glad to see that we hopefully will be getting to enjoy that again this fall. So in the way of my training, I did my undergrad at the Georgia Tech in Atlanta. So again, back to Georgia. I did a lot of my medical school as well as orthopedic training at the Medical College of Georgia in Augusta. And then after that, I spent a year in the cold Northwest or Midwestern North at the Mayo Clinic doing a fellowship in shoulder and elbow reconstruction. Mayo Clinic has been ranked the #1 hospital in the United States, I think now for the 3rd or 4th year in a row. So it's got a great reputation. And I was very fortunate and blessed to be able to work with those, the folks up there. I was able to complete a shoulder and elbow reconstruction fellowship, which is one of the few ASES recognized fellowships in the entire country. There's only a handful of these, and it's a very small, relatively elite group of places that you have the opportunity to train. I worked with some of the best researchers and top implant designers for elbow and shoulder reconstruction manufacturers in the United States and the world, as well as we really took on a lot of the more complex shoulder and elbow operations each year there, more so there than anywhere else in the United States. So that was really what set me up for success. We completed over 450 procedures. We did publications, did a number of international and nationally recognized research components that got presented again in a number of places. And so it was really a great opportunity. And then I had the opportunity to take this and bring it back to East Tennessee. And so I always show this picture and say, this picture on the bottom right was my backyard up in Minnesota. And so while I enjoyed these sights and sounds, I much prefer to look at my backyard and see pictures like this of the Smoky Mountains and beautiful East Tennessee. This is really where my wife and I and our family are glad to be back and seeing pictures like this and not quite as much snow. So we're glad to be back here. Again, the topic today is tennis elbow. We'll talk about minimally invasive treatment options, including non-operative treatment. But first, we should talk about a little bit about what is tennis elbow. Well, the other name for it is lateral epicondylitis. And so lateral epicondylitis is a little bit of a misnomer, but it's very common. And tennis elbow, as we have come to find out, is not just for tennis players, but it does affect them too. So Serena Williams, who's obviously a famous tennis player, this was the ailment that took her out of the one of the big tournaments in the Swedish Open a few years back, about 4 or 5 years ago. And this was the same ailment that literally derailed her from this tournament. So it can really be debilitating if it's big enough and bad enough that it stops, an elite level athlete, then it can be pretty debilitating. With that said, this is a picture of one of my former mentors and elbow surgeons, Mark Morey. He and his father are kind of godfathers of shoulder surgery. And it affected him as well when I was up there. So it goes to show you, and you can look at Dr. Morey and tell that he's not as much of an athlete as Serena Williams, but he does have a lovely family and he enjoys playing tennis. And so at the end of the day, it goes to show you that it can affect elite level people like Serena Williams, and can affect the more run-of-the-mill common, he's a surgeon, but again, it can affect anybody. So I just put that picture up to show you that it can affect people from a broad range of backgrounds and kind of caliber of athletes, or not so much athletes sometimes as well. So in the way of history, this is an etiology that has been described back as far back as 1873. It's more of a tendinosis and is not always an inflammatory condition, although we often talk about inflammation around the elbow. At the end of the day, it is a stretching and wear and tear phenomenon that can affect the extensor muscles of the outside aspect of the elbow. And when that area becomes irritated, it can become quite debilitating and painful. It tends to affect the what we call the extensor muscles, which is at the top of the forearm. You can see here in this picture, the top part of the forearm where it attaches to the elbow, but it tends to do more with the actual motion of the wrist. And that wrist, as we move our wrist and we go on about our daily activities, can become compromised and painful. A little bit about epidemiology. Incidence is roughly 3% per year, but that, depending on what you do, you realize that could go up to 4 or 7%, or up to as high as 10 to 50% people who do play tennis regularly and do other more competitive kind of sports. So it can be a pretty big ailment for people that are manual laborers or do things that are repetitive tasks with your hands and your wrists, even people that do a lot of keyboard and typing, that type of thing. So it's not just tennis players by any means, but a high incidence in those groups, but as high as 3 to 8% of just regular, what I would call the average middle-aged patient. And happens a lot more on the outside of the elbow compared to the inside of the elbow, but it can also affect the inside part of the elbow. So the average age is somewhere between the age of 35 and 55, but I've seen it as early as 18, and I've certainly seen it in people a lot older than 55. It tends to affect females and males about equally, and it tends to be the dominant arm. So if you're right-handed, it tends to affect your right side. Again, a little bit, this was a really well done study done out of the Mayo Clinic, oddly enough, and I know I'm not being biased with that, but bear with me on that. It was a really good study that was done over a 12-year period. It looked at the incidence of this, and the annual incidence in their study ranged from 2% to 4.5% or almost 5%. And so again, somewhere in that 3 to 5% range is pretty common in most studies. The tricky part is that the recurrence rate is almost 9%. And so you can have people that have treated this and gotten better, but it comes back on them. So that's something to keep in mind as we talk about treatment options. So this is a little bit more about anatomy, and hopefully these pictures come across clearly and you can maybe better understand what the offending agent is. And so the extensor group of the elbow, they all insert here on the outside part of the elbow. And this is the, coming down from the top here, you'll see that this is the outside part of the elbow. And this is where these tendons all insert, and they kind of coalesce into this one little area here. And the common culprit is this guy right here, what we call the ECRB, or the extensor carpi radialis brevis. That's a fancy term for essentially the tendon that helps extend the wrist. And this tends to be the real origin of the problem. The tricky part, though, is that when you look around the elbow, you see you look at this diagram on the right, and there's actually 4 or 5 different tendons that all come together in that one area. And there are also nerves down here. We have the radial nerve and the sensory nerve and the PIN. So we have other nerves that can also come into play here. But more commonly than not, it is the ECRB tendon that is the main culprit and the main pain generator. So a little bit about the biomechanics of this, again, excessive and repetitive use of these extensors and the twisting of the wrist. So that's why you see it in manual work. You see it in typing. You see it in tennis players. You see it in all these people. And these can all lead to this kind of overuse phenomenon where you're contracting these tendons and they become inflamed and kind of tendinotic and essentially can become non-useful and become quite a source of pain. The diagnosis, we do tend to get x-rays, but more so than that, it tends to be a diagnosis of history and exam. The history is very common that it starts at the lateral, the outside aspect of the elbow. It radiates down the top of the forearm and occasionally can come into the, into the wrist and the hand, but typically it just radiates into the forearm. Occasionally it can radiate up the elbow a little bit into the bottom part of the arm. But again, these are exacerbated by contraction. And so it tends to not be so bad at rest, but can be very painful and bothersome with activity and with, gripping type activities, use, trying to hold items. I've had people tell me that, doc, it got to where I literally dropped I was dropping a cup of coffee out of my hand. I didn't feel like I could hold on to it anymore. So it's not always a tennis racket. It can be as simple as a coffee cup. In terms of the exam, oftentimes patients are tender right over this hot spot, right on the outside part of the elbow. When I ask people, point to where it hurts, they point right to this area. And so it's very reproducible oftentimes. And then we have a whole host of other exam maneuvers that I won't bore you with this evening, but essentially you go through these exam maneuvers and I'm usually able to tell this within about 4 or 5 maneuvers, whether or not this is probably tennis elbow or if this is something else. So we'll move a little bit into treatment options. And the treatment options, I put this picture up here because if you go on the internet and you Google tennis elbow, you will find so many braces, it will make you dizzy. And the reality is none of these things are really all that effective at treating the underlying problem. They sometimes can make you feel better, but the point of the matter is you can find treatment options that will last you for days and days and days. The vast majority of these treatment options are non-operative. I would tell you that, in my opinion, physical therapy is probably at the top of this treatment algorithm. Sometimes people tend to modify their activities, the way they do things, maybe take a little break from what they're doing on a regular basis or change the way they're doing it. And this can help. And sometimes that's all you need. And if that's all you need, then that's wonderful. Unfortunately, when people have failed these therapy and they've kind of treated it at home with Tylenol or Advil or ibuprofen, and they've kind of done these things, they've gone on the internet and got themselves some sort of brace from Amazon. And when that stuff has failed, they tend to come to see me. And typically the first step for me is actually therapy, because I am a firm believer, and it's not just to tout our therapy guys, and they are great, but the reality is, a lot of tennis elbow and lateral epicondylitis does respond to therapy. The trick with that is that it has to be the right therapy. It can't be any therapist, and it can't be any Joe Schmo that just thinks they know how to treat tennis elbow. They have to be able to do the right things. And unfortunately, it is not uncommon that I see people that have had, quote unquote, had therapy, and we start talking about what they did, and frankly, they were just not being treated correctly. And so then they go to therapy and the appropriate therapy, and they come back and say, wow, doc, yeah, I'm better now. I just wasn't getting the right therapy. And so that is an important part of tennis elbow, and I'm happy to educate people through that, but it is an important part. When that fails, we do have other minimally invasive treatments such as PRP and biologics. And then if that fails, we do have pretty reliable surgical techniques. But what I would tell you is that the vast majority of people respond to non-operative treatment. So in terms of therapy, this was what I was alluding to. Eccentric exercises and eccentric stretching is a key component to getting yourself better if you do in fact have tennis elbow or lateral epicondylitis. If you think about an eccentric contraction, it's a little bit counterintuitive. If you think about lifting a dumbbell and you're going to do a biceps curl, for instance, and you bring this up, as you flex your muscle, the muscle's getting shorter and it's also contracting. Well, that is what we call a concentric contraction. And that is not what we need to do. So again, it's counterintuitive. What you really have to learn how to do is eccentrically strengthen and stretch the appropriate muscles in the forearm and around the elbow. And so that's why it's a little bit tricky. And there's a whole host of exercises, but the important part is that you have someone that knows what they're doing and is educating you in the right type of exercises. These are two of my favorites for tennis elbow. But again, it takes someone showing you the right way to do this in order for it to be effective. And so hopefully we're able to educate you and get you on the right track, toward improvement with these eccentric exercises. We have a great therapy group here at TOC that can help you here. But again, there are a lot of good hand and elbow therapists out there that can get you on the right track. But it needs to be someone that for lack of a better word, just knows what they're doing. We also have handouts we can give you. If you remind me, I have handouts for this that can give you a little bit of a reminder on the right way to stretch and the right way to strengthen these muscles. So again, we have a whole host of non-operative treatments, but what happens if I'm not getting better? Dr. Kennon, hey, I've tried these therapy exercises. Maybe I'm a little better, but honestly, I'm not getting that much better. What is wrong? Why am I not responding to this? Well, fundamentally, tendons have a poor blood supply, and they have an abnormally low ability to heal themselves in the elbow. And so because of that, the tendon oftentimes has these little, what we call micro tears in the elbow around this ECRB tendon. That's the problem. And oftentimes they don't have the natural ability to heal themselves on their own. And so those tend to be the people that fall into the category of needing a little bit of extra help. They need a little something different and a little extra to help themselves get over the hump and really stimulate this healing process. And so sometimes pain, tenderness, swelling, and impaired performance can occur secondary to this poor blood supply. And so one of the neat options is, we say, well, what do we do? What can we do to help, stimulate this healing process? Well, the two most common ones that if you've already seen your primary care doctor for, a lot of those guys and gals, they will provide you a treatment that they, in their defense, they think is probably the right thing to do. And I would not argue it's the wrong thing to do, but I would tell you that, if you talk to experts in the shoulder and elbow field, I would tell you that at least here at TOC, in Park West and even in Oak Ridge, the two places I primarily go, the people that do the most elbow are myself and two of my colleagues, and we all have a pretty good consensus agreement that just sticking steroid injections into the elbow is really not the appropriate treatment. But unfortunately, that's still kind of commonplace out in the community where you will see, I'll have patients come to me and they say, Doc, every time I get a steroid injection in the elbow for this tennis elbow, it gets better. And so that's what I want you to do. And unfortunately, we have pretty good studies now that show that those steroid injections into the elbow can cause atrophy and muscle wasting and can actually cause permanent structural damage to the tendon. And so I say that to tell you that I'm not completely opposed to steroid injections in the elbow. And in fact, I do perform these sometimes, but it's in certain people, and it's certainly not my first treatment option because to me, I don't want to do damage to patients in their elbow that may be irreparable to those tendons unless I know that we've really exhausted other options. And frankly, for me, I oftentimes have what I think is a better treatment option for them rather than a steroid injection into this elbow. And so, I don't jump straight to that for most people. It is an option. It is on the table, and we will talk about it, but it's not my first treatment option. The other thing that I oftentimes see is non-steroidals. And so that falls in the category of, ibuprofen, Aleve, Advil, meloxicam, Mobic, diclofenac. These are all these categories of anti-inflammatory medicines that a lot of times people have tried before they've gotten to me. And again, these can do wonders for tennis elbow, but they come with some drawbacks. There are people that have kidney damage or gastrointestinal, like GI, stomach upset, those kind of problems from taking too many anti-inflammatories. And so for me, again, is it an option? Yes, absolutely. In certain people, we talk about it and we do this, but it's not always the perfect solution for everybody. So what if you come to me and you say, well, doc, I've tried I've been on ibuprofen and Aleve for years and it's not doing the trick. I've tried the therapy and I've tried steroid injections. What else is out there, doc? And so one of the new and more exciting technologies we have is something called platelet-rich plasma. It's a really neat, it's essentially a minimally invasive approach to try to stimulate the body's natural healing potential. And so PRP injections, what we do is we essentially take your own plasma and blood cells from your body. So it's your own body's natural healing abilities. And it's almost as if we hype this up and we really concentrate the body's platelet-rich plasma, which we know stimulates the healing process. And then we put this back into the elbow. And so it's kind of a neat process in that you're not really taking outside chemicals and steroids. We're kind of taking your body's own natural healing potential, souping it up, and we're putting it focused back into that tendon that is the problem in the elbow. And so it can really potentially accelerate the healing and reduce injury recovery time. So again, platelet-rich plasma is really neat. It's an early blood, it stimulates this almost what we call super physiological concentration of these growth factors and stimulate the healing process. And so I will tell you that it's very exciting. It's a relatively newer advancement in tendon treatment problems that we have only really been doing for a handful of years. What I can safely tell people is that it is a safe option. And so you say, well, Dr. Kennon, then why in the world are we not doing PRP for everybody? Well, I'll tell you the two big negatives. The first negative is that it does not help everyone. And so the literature and the studies are a little bit varied. There are some studies that show that it might not do any better than any other injection. And so when that study comes out, you go, oh man, maybe we don't need to be doing this. But for every one of those studies, there's another 2 or 3 that come out that show a significant difference in this compared to a steroid or another injection type. And so my education of patients is that I think it's helpful and that I think that the vast majority of people will respond to it, but I wouldn't want to promise you that. And the reason being is that there are some people that don't respond to it. And so I tell people you have to go into it with the mentality that I've tried everything else, but I want to try something short of surgery. And in my opinion, that's where PRP comes in. The other big negative to it, and I'll be very frank with patients about this, is that it is costly. Right now, insurance companies or most insurance companies don't really cover this. And so it is an out-of-pocket cost. And so I tell everyone that, look, the last thing I want anyone to think of me is that I'm some sort of snake oil salesman and I'm trying to, pitch this PRP thing to you and get rich. And I would tell you that it's really not the case. The unfortunate part is that insurance doesn't cover it. And so you have to know that, you have to go into it understanding that. And that's why I don't hide, anything about that. I'm very forthcoming with patients that, look, this could be, this could be quite a really turning point for you in your recovery and could be an absolute game changer for you. but you got to be willing to take the risk with me. And that's a financial risk, but also being able to say that, it's not going to help everybody, but a lot of people, it really does help. I will tell you a personal story. One of my medical assistants that helps me out in the clinic, and you'll probably meet her if you come in to see me. Her name is Andrea. She helped me out. I just got done working with her today. She had tennis elbow for a number of years, got a PRP injection in her elbow, actually not done by me, so I'm not even going to take credit for this one. And she's told me today before I did this talk, I said, Andrea, is your elbow still feeling better? And she said, absolutely. She said, I did that 2 years ago and I have not had a problem with it since. And so for some people you go, well, heck, I would rather do that and maybe take the financial risk versus years and years of therapy or surgery or other treatments. And so, again, I think that PRP is an option. And I think that it serves a place when we talk about treatment for patients. But I don't want to fill you full of, promise and hope that it may not help everyone, but I do think it's something that we should be discussing. And again, not everybody does this. This is something that myself and only a handful of other people even do, here in East Tennessee and at TOC. And so you kind of have to have somebody that's educated and that knows a little bit about this. So again, food for thought. Well, what if we failed everything else, Dr. Kennon? What do we do then? Well, is surgery even needed? So let's take a step back and let's talk about this. When you look back at some of the literature, people would tell you that lateral epicondylitis or tennis elbow, these are things I've read. It's the acne of middle age. Everyone gets it. We don't really know why. It's harmless. You'll eventually grow out of it. It'll eventually go away and you should just deal with it. That's kind of the historical treatment options. And that's what doctors used to tell patients. And with all that said, you know what? We have our own orthopedic literature. This is a very well done review article that says, well, you know what? It's an expected rite of passage through middle and latter age, and it's a result of overuse, and that symptoms will resolve in 80 to 90% of people within 12 months. And so, maybe it is a condition that's just like getting gray hair or arthritis or farsightedness. It's just a rite of passage. And, I've had people tell me that they did have it when they were younger and it just got better. And so, maybe there is some truth to that if you change the way you're doing things, that this will get better. So I don't want to, tell everybody they need surgery. But at the same time, there are a lot of people that don't necessarily get better and do need a little education and coaching along the way. So when do we talk about doing surgery? Well, for me, I would absolutely exhaust, our non-operative treatment. And then the other part would be that sometimes we have people that are a little more high demand and they say, Doc, I don't have 12 or 18 months to let this get better. I do construction. I swing a hammer for a living, Doc. And if I can't swing a hammer, then I don't eat. And if I don't eat, I can't pay my bills and I can't feed my family. So sometimes those people tend to be a little more aggressive with wanting to get something done. And, turns out if I couldn't operate for 12 months, then I would have a hard time paying the bills too. And so, if I have tennis elbow, I may be a little more aggressive with getting things fixed too. But with that said, I tend to tell people that we really should give this some time and we really should wait till this is, more really affecting your ability to perform work and take care of yourself and those things before we jump into surgery. So, again, prolonged symptoms, pain that's affecting your ability to take care of yourself. ADLs is what we call activities of daily living, meaning, being able to brush your hair, brush your teeth, doing those kind of things. If you get to where you can't even do those things, then you probably need to talk about seeing somebody and maybe getting something done. So how many people get surgery? Well, again, only about 3 to 4% of people that are diagnosed with tennis elbow end up needing surgery. Again, the vast majority of these people, this one study showed that the average time from diagnosis to surgery was almost 300 days. And so that's almost a year for people that they've dealt with it for 6 months to a year before they decide that they need surgery. And, I don't think this is unreasonable. Some people come in, they want it done within 6 or 8 weeks, and that's fine. But for the majority of people, we can kick this with non-operative treatment, not jump straight to surgery. Well, moving forward, what happens, right? Now we're on the same page. We've got a patient, you tell me, Dr. Kennon, I get it. I've tried all these things. It's been going on for a year, and for whatever reason, I'm ready to talk more about doing something. So what are our treatment options if you failed all these other treatments? Well, there are 3 big categories. We have percutaneous debridement, where we do it through a little small incision in the office. I would tell you that this is not my personal preference. I would tell you that this has kind of fallen out of favor for a lot of patients and a lot of surgeons as well over the years. It's a little bit antiquated, in my opinion. I think that if you're going to do it, you should do it right. And so if you're going to go through or have a procedure done, then you probably need to look at doing it one of 2 other methods, which is open or arthroscopic. And I think that they both have their place. I think that there are some patients that they have had such a debilitated tendon injury that sometimes we need to be prepared rather to actually perform a repair of that tendon and not just clean it up and debride it and help stimulate healing. And so for some people, I do say, we may try this arthroscopically, but we may need to open it up and actually do a formal repair. And so I tell everybody that we may do one or the other. But my actual preferred treatment method is arthroscopic, because if we go in and debride this tendon and clean up the bad diseased tissue and we stimulate the healing process, then we can actually get people back to a quicker recovery. We can also decrease the tissue trauma. We can minimize our wound problems and wound complications by doing it arthroscopically. And the biggest thing, so for those of you that are not familiar, arthroscopic means using a very small camera that is about the size of, smaller than a pen, like a writing utensil, a pen. It's smaller than that, and I can do this procedure through 2 incisions smaller than the size of your pinky. And so if you think about it like that, it's a very, very minimally invasive approach, and I can achieve the same, sometimes arguably better outcomes through this treatment option, and it really minimizes your risk. And so this was a systematic review where people were looking at arthroscopic versus other, all 3 of these approaches. And this was a really well done study. It covered a review from 15 years. And again, a very well done, very, just a very well orchestrated study that I think a lot of people look at when they decide, how should I be doing this type of treatment? And, it covered 30 different studies and looked at 1,600 patients. And so a very, very well done study. Again, a broad range of treatment. But again, even in this study, you could see that almost, between the 2 groups, almost 90% was done open or arthroscopically. So again, that's the vast majority of the way people do these procedures. And in my opinion, probably one of those 2 treatment options is your best option. But here's why I choose arthroscopic. If you look at these statistics, surgical site infection after arthroscopic debridement, 0%. Hematoma or a blood accumulation, 0%. The VAS and DASH scores are basically fancy scores for how do patients do with it overall in terms of outcomes. And those scores are right there, just as good, if not better, as the other treatment options, but we have a lower complication rate. And so in my hands, my preferred approach for most patients is an arthroscopic technique. I can also tell you that I know for me, it's myself and maybe one other surgeon here in all of Knoxville that actually is trained to do it this way. And again, the reason I do it is because, frankly, I think that it is a lower risk and a higher success rate. And it's easier recovery. So for me, those are the reasons that I prefer that approach if you're a good candidate for it. And so just a little bit of a technical aside here. How do we do this? Well, this is a diagram of the elbow looking at it from the inside. And you can see again right here, you see this ECRB tendon. This is the culprit. This is the guy that we really have to debride, clean up this tendon, and really stimulate the healing process. And so what I do is I want to take out some of the capsule. I want to take out I want to come through that area. I will sometimes take down a little bit of this ECRL tendon if it looks unhealthy, but primarily I'm trying to get my instruments in there arthroscopically through the size of a writing pen or a pencil and use this special equipment to help clean up this ECRB tendon. Once you do this, you see that we're able to protect the ligaments, protect the things that we don't want to offend or bother, and we're able to take care of the problem. In full disclosure, the reason this is part of my preferred approach is because I wrote the textbook article on this. This is one of the operative techniques. This is one of the main textbooks that all orthopedic surgeons read and learn, and literally learn how to do our surgery when we're in residency. And so they asked me to write part of this chapter on arthroscopic tennis elbow release. And so, I was honored to be able to have that opportunity to write that textbook chapter to help educate other surgeons about why this is probably at least a pretty good option to consider. So again, in terms of recovery, that's kind of the last topic here. People ask, well, how do people do? And, when do we get back to doing what we want to do? This was a really good study done in the Journal of Shoulder and Elbow Surgery, which is really the premier the premier journal for shoulder and elbow surgeons. And you realize that at about 3 months, people's average pain scores have dramatically dropped. So pain with activity was on average out of 100 was about around a 68, and that dropped to 19. So if you think about it like that, you're down to 80 to 90% improvement in about 3 months. And the pain score continues to dwindle down to over really a course of 2 years, but people see this big jump the first 3 months. So within 3 months, I tell people you're probably 80 or 90% better within 3 months. And then you just gradually, see that last 10% get better over the course of the following 1 to 2 years. But most people are back to work. They're back to doing the things they enjoy. They're taking care of themselves. They're really back to living a better life. And this was one of our patients. She just came in a week or two ago, and I said, oh man, I have this talk coming up. I need to take a picture of you. And so she's back, she's 3 months out. She's back to doing everything she wants to do. And this is a picture, a close up of her elbow. And I would challenge you to tell me where you think I operated, because she's 3 months out and you can barely find the wounds. I would tell you that I think for her, my incision was right around in here and right around in here. But again, at 3 months, you can barely find where we even did her surgery. And she's back. You can see she's giving you the old, the fist, like she's a happy camper. She's got no pain. She said, look, doc, this is best I've felt in 2 years with this thing. And so she's really doing well. And most people really do. The success rate's very high. And so in summary, it's a very common entity. It's about 3 or 4% of all the population, but can be as high as 10 to 50% if you're really using your arms and wrists and hands for a lot of repetitive activities. 80 to 90% of cases resolve on their own with the appropriate treatment within 6 to 12 months without needing surgery, but it may be indicated in certain cases. And again, excellent surgical outcomes, improved functional outcomes, and lower complication rates with my minimally invasive arthroscopic technique. And ultimately, we do what's best for you. I really do take the patient's needs and concerns into consideration, and I try to come up with a solution that's tailor-made for each patient. And so this is kind of my closing slide where I tell people, the reason you come to the doctor is to get better. It's not just to have a non-functional elbow. You need to know that there are treatment options out there, both surgical and non-surgical options that can make you feel better. We can, in the vast majority of cases, we can get you better. And so you don't need to live your life miserable and not enjoying the activities. I know these pictures are a little cheesy on the right. I kind of get a kick out of those that you see. I feel like it's a pharmaceutical commercial. But you can get back to enjoying your life. You're riding bikes and playing golf and do whatever it is you enjoy, cooking, cleaning, whatever it is, you enjoy, get back to doing those things. You don't have to suffer with pain and dysfunction. So with that, I will thank you for your attention. Hopefully I didn't put you to sleep there while you're eating dinner. And I think we got 15 or 20 minutes here for some Q&A.
Yeah, absolutely. Thank you, Dr. Kennon. With our more intimate group this evening, I want to thank everyone for being here. But if anyone has any questions, you are welcome to unmute yourself and go ahead and just ask Dr. Kennon a question. If anybody has any, or if you don't feel comfortable talking, you can absolutely put them in the chat box as well. And while everyone's kind of thinking of questions or unmuting themselves, just wanted to let everyone know that this will be sent out. It has been recorded, so it will be sent out to all the participants that were signed up today. And also I will send out how to schedule with Dr. Kennon if you would like to do so. But I think Miss Barbara may have unmuted herself.
I did. I have a question. How could I get a copy of the handouts for the exercises that you mentioned? You said if we ask, you might be able to come up with some.
Absolutely. Probably the best route would be if Sloan, who's helping orchestrate all this and probably who you organize this through, if you contact Sloan, then there's a very, I have no problem passing those along to Sloan, and hopefully she can be a liaison for us to help get those exercises to you. The big thing with that would be, there's certainly a good place to start. Oftentimes, if you don't respond to that, you may need to find a therapist to help work through them and make sure you're doing them kind of appropriately and kind of hitting all the check boxes, and not just, sometimes if you're doing the exercises, you may think you're doing them correctly, but you may need a little coaching or education along the way. But it's certainly a good place to start.
Mm-hmm.
Right.
Yeah, absolutely. Dr. Kennon, if you have those digitally, I can send them out. If not, Barbara, just send an email stating what you're needing to feedback@talkdocs.com, and I will get those mailed out to you. I think there's a question
Thank you.
in the chat box as well, Dr. Kennon.
Yep. So I will read it for everyone else. So it says, do you think that PRP will be covered under insurance in the near future? I have several docs who have used it. It's hard to say, honestly. I, for one, would vote for it. But as you can imagine, insurance companies do everything in their power to avoid paying things. That's how they make money. So I know that sounds jaded, but there's some truth to it. So I really don't have a lot of, much more insight than the next doctor does about that. I'm optimistic, but the reality is, we could be waiting for 5 or 10 years for that to come out. There are certain, treatments that I still think are probably good treatments out there for other problems, and they still don't cover them, even though there's pretty good literature behind it. So the honest answer is I don't know. The more detailed answer is that if insurance companies have their way, they will continue to avoid paying for it for as long as possible.
Thank you, Dr. Kennon. Anybody else? Anybody have any final questions? If not, we will let you nice people get on with your evening. And we thank you so much for joining us. If you have any questions at all, you're welcome to email the RSVP email, or you can email us at feedback@talkdocs.com. And like I said, I'll send a follow-up email out for everybody. So any questions you may have, feel free to send back to me, and I will send them on to Dr. Kennon.
Perfect. Thank you guys for joining. We appreciate it.
Thank you so much, everyone. Have a great day.